So we are now going to discuss about a very dreadful cancer, and a cancer which medical oncologists like myself and surgical oncologists like Dr. Anil Kamath find very difficult to manage in our practice. While we also will give you an overview of how we manage pancreatic cancer, it should be noted that any cancer, including pancreatic cancer, when diagnosed in the earlier stages, is highly curable. Pancreatic cancer is the cancer of the pancreas, the organ which produces the digestive juices for digestion. The cause for pancreatic cancer can be multiple, but many a times we know that smoking, alcohol, and various other abuse of the body can lead to pancreatic cancer. There are certain infections also which have been known to cause pancreatic cancer. Usually, pancreatic cancer can present with jaundice, pain abdomen, wherein you get pain on the right side because of the enlargement of the liver, weight loss, diarrhea, and multiple gastrointestinal symptoms. We believe that pancreatic cancer can present with a myriad of symptoms. So, whenever a patient comes with pain abdomen, we always resort to investigations.
Yeah, like Dr. Mangesh said, pancreatic cancer, not very common, but in terms of mortality, it is one of the important causes of mortality. In that way, it can be called a very dreadful cancer. Now, with regard to investigations, suppose what are the investigations that we do once we suspect that the patient has pancreatic cancer based on the symptoms? So the patient presents with obstructive jaundice. The initial investigations invariably is an ultrasound abdomen. This ultrasound will show the possible cause of jaundice, that the bile duct is dilated. That makes us suspicious that there is something in the pancreas. Pancreas as an organ is not very well seen on ultrasound because of the bowel gas. The next investigation which is commonly done is either a CT scan or a MRI of the abdomen. This is a much better investigation to diagnose that there is a mass in the pancreas which could be cancerous. A modified version of MRI, what we call MRCP, is done, which is called magnetic resonance cholangiopancreatography, which shows us that there is a mass in the pancreas and it is causing obstruction to the bile duct. It also shows us the spread of the cancer to the nearby lymph nodes. Nowadays, of course, we have the PET CT scan, which tells us how much the cancer has spread. Biopsy is a little controversial issue, though it is done in various ways. Nowadays, it is accepted that it is better to do a biopsy, though many times we do proceed even without a biopsy report when there is a clear-cut mass. Biopsy is now usually done by endoscopic ultrasound. That is, the ultrasound is attached to the endoscope, and under that guidance, a needle is inserted through the duodenum and some material is taken and examined under the microscope. Sometimes biopsy may have to be done externally through CT scan guidance. So these are the various investigations which are done. And following investigations, you have to reach at a diagnosis and a possible stage for the pancreatic cancer. So once we reach a diagnosis and stage, next comes the management. Surgery forms the key for management of pancreatic cancer. Now, depending on where the cancer is located, that part will have to be removed. The common location is the head of the pancreas. So most of the cancers arise there, and a few cancers arise in the tail of the pancreas. So depending on that, when the cancer is in the tail of the pancreas, we have to go for a procedure known as distal pancreatectomy, where the tail of the pancreas is removed. But when the cancer is at the head of the pancreas, this is a very complex area. Here, not only does the pancreas enter the duodenum, the bile duct also enters the duodenum. So it's a common passage for the bile, for the food passage, and for the pancreas. And removing these means removing all three of these. This procedure is known as a Whipple's pancreaticoduodenectomy. It's a very complex procedure, one of the very major surgeries performed in oncology. So in this, all these three organs have to be removed: the duodenum, the part of the pancreas, and the bile duct. And to reconstruct, the small intestine is brought up. And basically there are three anastomoses: one, the bile duct to the intestine, the stomach to the intestine and the pancreas to the intestine. It's a complex surgical procedures. It has its share of morbidity and mortality. Even in the best of centers, there is about a 5% risk of major complications. One issue which I should there is always a controversial issue, is that when the patient is jaundiced, whether the surgery should be performed immediately or the patient should undergo a stent. Stent is usually placed by the medical gastroenterologist by the endoscopic route. While stenting does bring down the jaundice, it also increases the chances of infective complications. Nowadays, most surgeons prefer to operate without the placement of a stent, because stenting is known to produce complications. But in specific situations, say the patient is very sick, he has got infection of the this one what we call as cholangitis, or is nutritionally very poor and may not withstand a major procedure. In these cases, we may opt to go for stenting prior to surgery. But once it is stented, we have to wait for a period of time, say about 1 or 2 months, before we perform the surgery. Once it crosses this stage, then comes the medical management and sometimes radiation. Yeah.
So basically, in pancreatic cancer, to just summarize what Dr. Anil Kamath said is, you will get a completely resectable stage where the pancreatic tumor is resectable as soon as the patient is diagnosed. Once you also get what is called as a borderline resectable case, wherein the tumor is not immediately resectable or operable by the surgeon, but there is scope to reduce the size of the tumor, and then the surgery can be done optimally. The third is an advanced stage where surgery cannot help and only medical management should help. So as Dr. Anil Kamath said, that depending on the location, you would do an immediate surgery for a patient with pancreatic cancer if it's immediately resectable. After resectable, it is worthwhile understanding that the tumor is not fully cured yet. You are not cured only by surgery alone. You will require what is called as post-operative treatment. It could be just chemotherapy or a combination of radiation and chemotherapy. The choice is basically depending on the experience of the oncology team that is treating you. Some people prefer to give a radiation and chemotherapy, and some people prefer only chemotherapy. So that is for borderline pancreas, that is for immediately resectable or resectable pancreatic cancer. Then you have borderline resectable pancreatic cancer, wherein there are multiple strategies, but the most common strategy is to give chemotherapy and downsize the tumor and convert the patient to undergo surgery. There are also centers which are doing radiation and chemotherapy, again with an intention to shrink the tumor or downsize the tumor so that the surgery can then be done. This is a very a cohesive unit is required of surgical oncology, medical oncology and radiation oncology, who can cohesively plan the treatment for the patient, because in pancreatic cancer you may not get second chances. You give the best treatment the first time, and then the tumor can you can hope for the best possible outcome, including a cure. But if the first management is not properly done, then it is very highly probable that the tumor will come back and will be rendered incurable. Now, when it comes to advanced pancreatic cancers, we rely on two strategies. One is to give chemotherapy, and as we all know, chemotherapy has to be planned in such a way that there are minimal side effects. But we will do this with the intention to not only improve the quantity of life of the patient, but also maintain the quality of life. There is a very, very small subset of pancreatic cancers which are spread through generations through a gene called BRCA mutation. Now, this forms a small group of pancreatic cancers called as hereditary pancreatic cancers, which can be managed with targeted therapies that are available today, by which the cancer can be controlled with targeted therapy and chemotherapy may be avoided. So, folks, we gave you in a nutshell, in this very small period of time, the entire way of our entire process of how oncologists like Dr. Anil Kamath and myself, we manage pancreatic cancers. And the best facilities are required for optimal management of pancreatic cancers. Thank you.
Thank you.